Good afternoon, ladies and gentlemen. Guten Nachmittag oder guten Abend schon bald. Hello to everybody here in the room and abroad, overseas. On behalf of the Bern University of Applied Sciences, I would like to welcome you, the audience here, and all the people who are following us to this guest lecture. A guest lecture. We have a guest from Canada today, Professor Doug Gross. I'm going to soon introduce him. But before this, I would like to thank a couple of people because without them, we wouldn't be here. That wouldn't be possible. So let me start. Thank Stefan Weffler. He is our study center and IT partner, and we have our communication unit. We have Barbara Kleffiger, who helped us to set this up, and of course also the Dean of the Faculty and of the Department, Urs Brücker and Eugen Mischler. As I mentioned, we have a lot of people following us, and I just want to mention them because they're in Canada, they're in Boston, in Connecticut, in the Netherlands, in Groningen, in Germany, and also in the UK. So we are really excited and thrilled that you are here with us. And of course, a couple of people also in Switzerland. So people from Poschiavo till Geneva are following the lecture too. So we are excited about that. And I would like to announce also the next guest lecture, which is on January the 30th. Oscar Franco, Professor Oscar Franco is the new head of ISPM, the Institute of Social and Preventive Medicine, and it's about cardiovascular diseases and what we should know and what we can do. So if you have your agenda, please note the next one, same time, same place. But now, let's move to Doug Gross. Doug Gross is a Canadian basketball player, former basketball player. He told me he's injured, so he needs a physical therapist or a healthcare provider helping him. We have a ton of them here, or a nurse. I don't know what you exactly need. He is a professor at the Faculty of Rehabilitation Medicine in Edmonton, Alberta. It's basically on the west side of Canada, but on the east side of the Rocky Mountains. For all of you who have been there, it's near the Rocky Mountains. And he has his focus has been on return to work research the last 20 years, where he developed several different research studies, one on more mass media campaigns in the province of Alberta, other more local level studies in a rehabilitation center where they trained healthcare providers, educate their people with low back pain and other musculoskeletal disorders. And then he did studies on motivational interviewing, behavioral intervention, and functional capacity evaluation. Again, we're thrilled, we're excited and honored to have you here, Doc. And we would like to thank you for your talk.
Well, thank you very much. Thanks for the invitation. I'm very pleased to be here in Bern. I flew out of Edmonton in a snowstorm, and I arrive here and it's sunny and plus 26. I want to tell my colleagues and my students, if any of them are listening, plus 26 here. It's like a tropical vacation for me. I'm actually in Switzerland for a conference that's occurring on the weekend at Clinic Valens, and Maurizio thought it would be a great idea for me to come and present some information about this Lancet series on low back pain to all of you. And then it grew and grew and grew, and now it seems like it's an international endeavor. So thanks to all of you for coming, and thanks to all of you who are joining online. I had a very minor role in this Lancet series, 2018. I'm going to talk about the papers more generally. If any of you don't have them yet, they're available open access. Everyone can download them. A series of 3 papers that were published last March. Maurizio also asked me to talk a little bit about the research that I have been involved in related to this, but also things that we've done in Canada related to management of back pain and musculoskeletal disorders. So I'll take this opportunity as well. So back pain. Many of you are experts in back pain, and basically I'm summarizing my whole talk here in this one slide. Back pain is very common, experienced by just about everyone. Very, very common reason for seeking healthcare. People trying to find a solution, finding a treatment that works for them. But unfortunately, for the vast majority of people, the cause is still unknown. There's no known cause, no known cure at this point. But what we do know is movement is best. And there's a variety of different interventions that can help people to continue activity, continue movement, continue work. And that's where I'm going to kind of move you to that summary. I'm going to go back in time to begin with, though. I want to put this in context. Before 1863, so looking back, way back in time, a couple of hundred years, most people didn't view back pain as a medical problem. There's a wide variety of beliefs about what caused back pain, what led to someone having back pain, and what they should do about it. You can see a few of them here. In Scotland, it was very common to think that an elf had shot you in the woods. Witches and demons throughout continental Europe. It was very popular here. Other ideas related to magnetism or humors. Most of these grew out of people's worldview. And like I said, most of them were not medical. They're not medical reasons for experiencing back pain. Back pain was just part of life. And people kind of dealt with it and moved on and went about their daily activity and business as much as possible. However, what happened in 1863? It was a publication of this paper in the Lancet, actually, the influence of railway traveling on public health. This paper very firmly entrenched back pain and other musculoskeletal conditions under an injury model, a medical type injury model. Before this, railways had kind of spread across England, and along with that came some minor and some major collisions with the trains. And when this occurred, some people did sustain injuries, others sustained more minor kind of conditions, but all of these symptoms and injuries were attributed to that collision that took place between the trains. And along with this idea that there was such a thing as injury of railway spine, there came a treatment, and the treatment, as outlined in this paper, was complete rest. Complete rest after such accidents is imperative, whether any inconvenience be felt at the time or not. So if you've been in even a minor bump on the train, or if you were jostled around, it was a really bumpy train ride, you want to rest after going through that. This is a kind of a slice, a screen capture of the actual paper, and look at some of the words that are used here. The after effects of collisions, though there may be no apparent injury at the time of the accident, are shown to be frequently highly injurious, even when not fatal. They're talking about injuries to the head, the spine, or the broader nervous system. These after effects may not be experienced for some weeks, but then headache, coma, death, from serious effusion, swelling in the brain takes place. So these are scary words. This is fearful, scary stuff. And the recommendation was for complete rest after any of these accidents or bumps on the railway. So that took kind of deep root in our collective conscious, this idea that pain is caused by an injury, and this injury is some sort of a tissue defect in our body. And when you look online now, if you Google headache or back pain, in this case I Googled back pain, what you're seeing are many, many images that grow out of this medical model. And many times, there is no specific injury that we know about in back pain, and so they have to produce even scarier images with lightning bolts or red, sometimes fire. All of these images are attempts to represent back pain when there's nothing that we can see typically. What is this overall idea about a medical type injury have? Well, it leads to fear. When you think that you have tissue damage like that, you're afraid. You think that you've got something major going on in your spine. That leads to worry, thinking that you've got a broken bone or cancer or something more nefarious. And what that leads to ultimately is anxiety that can be more debilitating than the pain itself. This is the fear avoidance cycle, right? As people start to think that they have a serious pathology, they worry about it, they become anxious, and they start seeking healthcare solutions while they rest and try to avoid aggravating their pain further. As I said, this spread, these ideas about pain, back pain spread very widely, and now, almost across the globe, people hold pessimistic beliefs about back pain, and they think that it requires medical investigation, medical treatment of the spine, and they believe that the best thing is to rest or protect the back, wear belts or braces, these types of things. In Canada, when we started our initiative to re-educate the public, we did some surveys. This was about 2005. And we found that around 50% of the population, still at this time, 2005, they thought that the best thing to do when they had back pain was to rest in bed until it got better. A little over 20%, so almost a quarter of the population, believed that back pain would ultimately lead them to being in a wheelchair. They thought that it was truly major pathology and something to be afraid of. We've seen this more recently in developing nations and in very isolated populations. So in Australia, there were a couple of research studies done on Aboriginal Australians. This was qualitative work. 1996, a study was published. These researchers went out and they interviewed and they surveyed Aboriginal Australians in the western part of Australia. And their conclusion was that this population had protective beliefs about the spine. They didn't think that back pain was necessarily a health issue. They still had it. They still experienced back pain, but they didn't think that it was a health issue that needed them, they needed to go seek out treatment. 2013, this study was repeated. Only now, the findings were very, very different. No longer did they view it as not a health issue. They were firmly rooted in the biomedical model. They held biomedical beliefs about back pain causation. They attributed the pain that they experienced to structural vulnerability of the spine. And how did they get those beliefs? Well, it was because westernized medicine started creeping out into their communities, along with x-rays and MRIs and the treatments, the medical treatments. So these, the Aboriginals themselves attributed new beliefs to advice that they received from interactions with healthcare providers, as well as the spine imaging results. They would see degeneration on an x-ray or an MRI. Their healthcare provider would say, yes, you've got a degenerated spine, it's falling apart, and you need to rest. Those kinds of beliefs did creep into their belief system. So it is widespread throughout the world. And when you look at the impact of back pain, again, this is a paper in the Lancet. They've been publishing the global burden of disease papers for many years now. And back and neck pain have been the single leading cause of disability since 1990. They've been number one in 1990, 2005, and most recently 2015, 2016 as well. The data that's come out, back pain and neck pain they win the day, basically. So back pain, leading cause of disability in 158 of 195 countries. It affects approximately 540 million people at any given time. And the costs are really astronomical when you look at it. Of course, there's variation across countries. I didn't have any data from Switzerland. I was able to track down these stats. $12 billion a year in Canada, $21 billion a year in UK, and $119 billion in America. So by far, the bulk of the money is spent in America. This was a quote at the bottom of the slide here I pulled out from one of these papers. It's the third highest bill for any health condition, despite evidence that most treatments do not work. Most of the surgeries, most of the imaging studies, these types of things don't work, and many times they do just the opposite, and they lead to more problems. So I Googled back pain treatment, and these are some of the pictures that came up. All kinds of things, from medication to surgery to traction beds, cupping type therapy, books and rubs and Medical marijuana there looks like one of them as well. So the treatments are widespread, all kinds of things that you can do. Many different solutions are marketed out there. But in reality, this hasn't solved the problem, and I really think that it's time for a rethink. And this was the idea behind the low back pain series in the Lancet. Before that, I will talk about one initiative that I was involved in Canada. This is related to a guideline that we developed related to the management of people injured in traffic injuries. So this was published in 2015. Pierre Coté led this team. The publication was called Enabling Recovery from Common Traffic Injuries. In this, there's separate guidelines for neck pain, for back pain, for extremity pain, and a variety of other conditions. Section 10 in this publication was a guideline on the clinical management of low back pain. I helped to do this study. Basically, we did a systematic review of available guidelines. We then synthesized and summarized those guidelines and published it. Since this time, there have been additional guidelines published. There was an update to the NICE guideline of low back pain out of the UK. The American Family Physicians Group published a guideline. And so with the new guidelines, knowing the impact and the burden of low back pain, the Lancet series agreed to publish a series of articles related to low back pain to really have this global call to action. Let's do something about this. We've made the problem so bad through these ongoing treatments that are out there. We need to change direction, change the course, and come up with a better solution. Rochelle Bookbinder, who was the low back pain author on the Global Burden of Disease study, led a working group. Well, there's a steering committee and a working group to author. Initially, it was going to be 5 papers. Lancet ultimately agreed to publish it in a series of 3. The first paper is what low back pain is and why we need to pay attention. Second one is prevention and treatment of low back pain, evidence, challenges, and promising directions. And lastly was the call to action, global call to action. I'm going to summarize each of these, and then hopefully we'll have some time at the end to talk about this and have a discussion. Here's the steering committee. As I said, Rochelle Bookbinder was the lead. There is a variety of people from around the world on that steering committee and a variety of people from across the world on the working group. Stefan was from Switzerland. I think he works in Geneva, at the University Hospital of Geneva. He was the Swiss representative on the team. I was a Canadian representative on the team. So let's start with number 1. I've kind of summarized this paper in my background to it. We know that back pain is extremely common. We know that it has this very prevalent, global point prevalence of 7.3%, 540 million people at any given time. We know that back pain is a symptom. Back pain itself is not a disease. Back pain is a simple symptom that people experience, and it can result from a variety of different conditions. These may be known or they may be unknown or unknown abnormalities or diseases. We define this pain by the anatomy, by where it is on the body. It's low back pain because the pain is experienced typically between the lower rib margins and the buttock crease. We know that back pain is commonly accompanied by pain in one or both legs, and some people have associated neurological symptoms in the lower limbs. And lastly, for nearly all people with low back pain, the specific cause, that tissue injury or insult, the specific nociceptive source, cannot be identified reliably. And these people are classified as having the so-called nonspecific low back pain. And I know that that's a controversial term, but the reality is, most of the time when you take an image, even if you see something on that image, you cannot guarantee, in the case of simple low back pain, that what you're seeing on the image is caused or is causing that pain. Other times there is a distinct correlation between the image and radicular symptoms, numbness in a certain dermatome, those types of things, but those are rare. The bulk, the vast majority, are in this nonspecific category. In paper 1, we present this model, contributors to low back pain and disability. So we know that there's this nociceptive input, We know that that input is processed centrally in the brain. We know that there's this interaction between the pain experience and disability, the behavior that arises from that. And around that, influencing both of these, we know that there's a variety of biophysical factors, comorbidities, social factors, pure psychological or mental factors, as well as genetic factors that change both the perception of pain as well as the behavior that arises from it, the disability. So we are recommending viewing back pain from this biopsychosocial perspective. Having said that, the bio is still very important, and there's still a lot of research going on and some observations that have identified, as I said, some specific abnormalities on the MRI or CT scan, and those have been found to correlate with low back pain or the other symptoms that come along with it. But, so some MRI findings are associated with low back pain, but for the vast majority, as I've already said, it's not possible to accurately identify the specific source. If you take a general person with back pain off the street and ran an MRI, you might see something like this. You look at that hard enough, you're going to be able to see some osteophytic lipping, you might see some degenerated disc. This is my MRI, and I've never had a day of back pain in my life, certainly not a day of disabling low back pain. So routine MRI is not recommended. We should not be routinely doing MRI on everyone that comes into the clinic with back pain. And in fact, we know there's some evidence showing that that's counterproductive, and it actually delays their recovery, and it gives them these beliefs that are incorrect. So that's paper 1. Paper 2 moves on into prevention and treatment of low back pain. The nitty-gritty. We try to summarize the evidence. As I said, it was based on some of the newer guidelines that came out, so we synthesized these guidelines. And then we made an attempt to outline some of the challenges as well as promising directions. Some of the research that has not yet made its way into guidelines, but we think that it's pretty good ideas, and it's looking very, very promising. We do know that much of modern back pain care is ineffective, often harmful. When you think about the high rates of surgery, last year I attended the North American Spine Society, and there is so much surgical intervention that's going on in the United States. I know that you have probably a lower rate there. We certainly have a lower rate in Canada, but there's a lot of ineffective surgery that's going on, from fusions to artificial disc replacements to you name it. We know that non-evidence-based practice has been observed and is apparent across all income settings. So it's not just high income, it's not just the United States and other high income. It also occurs in middle income and low income countries. And in fact, the number one most common treatment in low income countries is bed rest, which we know that hasn't been recommended in the guideline for decades. So what does the evidence say about, I'm going to talk about preventing low back pain, and I'll talk about treating disability from low back pain. So think about the different treatments that are available for low back pain, the belts, the ongoing kind of serial manipulation, spinal hygiene, insoles, medication. Yeah, there's no evidence around those, no consistent enough high quality evidence to make it into the guidelines. The only thing that has been recommended consistently is education with exercise or exercise on its own. The common question when I present, I almost always get asked, what's the single best exercise? And it's what you like to do, right? What does a person like to do? What will you stick with, and what will you be able to do on an ongoing basis? So I wouldn't say that there's 5 best exercises out there. I don't think that there's one best exercise. But the evidence does support exercise as the best way to prevent new episodes of low back pain. Here's the table right out of the Lancet series, paper 2. You see at the top there, exercise and education effective in adults, exercise on its own effective in adults. But even those two have low and moderate quality exercise. All the other ones, back belt, shoe insoles, and the others, it's either shown to be ineffective or there have been no trials done. So prevention is an area where we definitely need lots more research. How about preventing disability from low back pain? This is where a lot of my research has focused on. There's probably a bit more that we know about ways to prevent disability. The American guideline made quite a dramatic, this American Family Physician Guideline that was published in 2017, it made a very dramatic shift, trying to move away from surgeries and narcotic prescriptions and so on. It was summarized in the Scientific American magazine with this headline: "Forget pills and surgery for low back pain. Let's get away from that." With the subtitle, "Many physicians are advocating a simpler approach to treating lower back pain: exercise." And then in the paper itself, they go on and they talk about a lot of other things besides exercise. As you see in the bottom of the slide here in the picture, that's like a yoga pose, a meditation pose. So we'll talk about some of the other things that they recommend. But many other things are done in the clinic. I'm a physical therapist. When I treated, traction was the biggest thing. It was the late 1990s. We used traction on just about everybody. TENS was used just about on everyone that came into the clinic, hot packs. And Tylenol is the single biggest medication that is prescribed worldwide for back pain. Well, we know that the evidence for all of these things is not there. They've either been shown to be ineffective or, in the case of traction, potentially harmful. I'll go through pharmacological therapies. Excuse me. Then I'll talk about surgical therapies, and lastly, we'll talk about the non-pharmacological therapy. So, the very top there, paracetamol, that's Tylenol. It is no longer recommended. The medications that can be considered, and you see that these are considered for second line or adjunctive treatment options, non-steroidal anti-inflammatories, and opioids. We were kind of on the fence with opioids, and even in that Ontario guideline that we published, the Optima guideline, it's a really controversial area. So in the Lancet series, the recommendation was limited use in selected patients. It's definitely not something that you would consider for widespread use, and definitely use with caution. Monitor the patients, give them trials, monitor how they do, follow up routinely. Everything else is either insufficient evidence or role uncertain. Interventional therapies, these are injections or surgery. You can see the evidence there around acute low back pain. No evidence related to any type of surgery, insufficient evidence. Although in some of those more specific cases, it's recommended as a second line or adjunctive treatment for herniated disc or symptomatic spinal stenosis. The injections, epidural glucocorticoid injections, not recommended in acute pain. And we said limited use in selected patients with chronic conditions. But again, the evidence was very mixed and not necessarily great. What is the first line recommended treatment? Well, it's shown here in both acute and low back pain. It's advice to remain as active as possible and education. We don't get into a whole lot of detail about that in the Lancet paper in this table, so I pulled out some of the specific recommendations in the Optima guideline. What type of education should be provided? Reassurance. So number one, knowing that these patients are coming in thinking that they might have something major, they're worrying, they have a lot of fear, we do need to provide that reassurance. Reassure patients about the benign and self-limited nature of their pain, educate patients about the benefits of being actively engaged and participating in their care plan by remaining active and continuing movement. We're not saying go out and run a marathon or start a weight training program, right? This is staying as active as you can. Go for a walk. Keep up your work activities as much as possible. Keep up your hobby and your sporting activities if you can. And the last one is emphasizing active rather than passive treatments. So that's, again, first line, the only first line treatment for both acute and persistent chronic low back pain, exercise and advice. However, there are several supplemental therapies, secondary therapies that can be provided. These have all been shown to be fairly safe and effective. Simple physical and psychological treatments to help people stay active. Again, you need to think about these as secondary tools or approaches to support that first line approach of staying active and reassuring the people. In the Optima guideline, we did find pretty good evidence for these wearable hot packs. A couple of excellent randomized controlled trials have found that those do help people stay active. Massage, acupuncture. Now, I know acupuncture is kind of a controversial one, and the NICE guideline took it out. The American guideline kept it in. So the Lancet series actually recommends it as a potential second-line therapy to help people stay active. In the middle there, you see exercise and manual therapy, hands-on mobilization, manipulation. Those are definitely effective and help people to stay active. And over here is psychological therapy. Cognitive behavioral therapy. Now, this is one that was somewhat controversial, but the evidence is actually quite good, especially in chronic pain. So all of these could potentially be offered for patients with acute or persistent low back pain. You'll see that exercise therapy and cognitive behavioral therapy are limited use in selected patients, but then recommended more as even potentially first-line treatments in chronic pain. Everyone with chronic pain should have some sort of an exercise program, and they should have some sort of psychological support to help cope with that pain. And most of the others are considered a second-line or adjunctive therapy, except for yoga, mindfulness-based stress reduction, and interdisciplinary rehabilitation. In acute back pain, there's not a lot of evidence supporting those. In acute back pain, much more evidence for persistent. So this is when I was talking about that article that said avoid pills and surgery for low back pain, try exercise instead. The US guideline does recommend many of these as supplemental in addition to exercise. So, promising new directions. That is a quick summary of the guidelines, and all of these guidelines are available on the line. Online. You can track them down and read the recommendations yourself. What about promising new directions? What is the evidence pointing to as something that might be more effective than what we currently have? These are summarized in three big kind of topic areas, one related to public health, one related to social and work systems, and lastly, healthcare solutions. How do we provide healthcare differently? I'll go through each of these differently. I do want to say that in my interpretation, these are no longer just operating in that biopsychosocial model. I would say that this is expanding out into what we call a socio-ecological model, which still has bio, psycho, and social in it, but it recognizes the real importance of that broader area, the social interactions, the policy and legislative context, the physical environment in which people work and play, as well as the social environment, the peer-to-peer interactions, the friends, the family, the work colleagues, and so on. Public health solutions, we know that this type of education provided in the clinic, pointing at the disc bulge or whatever it may be, that actually is counterproductive. We know that we can actually change what people believe and make them think that they have more problems that are going to make them more worried about their pain. So we don't do that. Guidelines typically do recommend more standardized approaches to education. You can provide the education about reassurance and talking about the benign nature of pain, that they don't have cancer and so on. You can do that verbally, or you can provide standardized booklets like the back book. There's pretty good evidence that these do help people in their recovery. But the public health solutions that I'm talking about are things like this commercial.
This message is for doctors. If you're not a doctor, look away now.
Most people can and do deal with back pain themselves most of the time. So what do doctors themselves do with their own backs? And the answer is that they do exactly what we're now saying that patients should do. Doctors do not go rushing off to see a surgeon or to get an X-ray or a CAT scan of their back. They may well need to modify how they do their job a little bit for a few days, but they stay active, they stay at work, and they expect to get better. So really the message that we're saying to doctors is, treat your patients just the same as you treat yourself.
Endorsed by the Royal Australian College of General Practitioners.
So that was Gordon Waddell, right, the very famous Scottish orthopedic surgeon. But it was an ad in a campaign that was ran in Australia in the late 1990s. This is an example of a public health approach, trying to get out into the community, present this information about back pain, that you want to stay active, reassuring people that they don't have something serious. That study showed a large impact, a really huge impact in the general public. It reduced disability. Fewer people were filing workers' compensation type claims. More people were staying active and continuing to work. So it had an impact not only on the pain experience, but also on disability and the behaviors. But nobody's been able to replicate that. We've tried it in a few different countries. Scotland had a campaign, Norway had a campaign, in Canada we've had a campaign. We've had our campaign going on for 11 years. I've been evaluating it. We have a couple of papers that have come out around its impact. I'll play you one of our radio ads. One of the biggest reasons we haven't been able to replicate it was because Australia had a ton of money. There was $9 million that went into creating and buying television time, and nobody's been able to come up with that amount of money, and so we do it kind of on a cheaper, more limited basis. In Alberta, we kind of took the Gordon Waddell approach in Scotland and used radio advertisements. I'll play one for you.
Oh, hey there, Margie. You look like you got some back pain there.
Yeah, Bob. I tweaked something yesterday when I was sweeping the ice at the curling tournament.
Shouldn't you be at home resting it then?
Wrong, Bob. Staying active is the best way to reduce back pain. Way to go, Margie. Way to stay active. There are lots of activities that can help you with back pain. Stretching, walking, swimming, and more. Back pain. Don't take it lying down. For more information on how to manage back pain, visit backactive.ca. And remember, staying active is better for your back.
So I built a little bit of the humor like the Australian campaign, built on our national pastime, right, curling, and hockey. These radio ads, they were shown in Edmonton, in my city. They were shown in between the Edmonton Oilers hockey games. Anybody listening to the game on the radio would hear these. So tried to localize it to the Canadian context. And we have had some success. Over the 11 years of this campaign, we've seen people's beliefs about what they should do with their pain go from about 55% people agreeing that they should rest in bed up to 75%, just over 70%, believing that they should stay active. So we've had about a 16% increase in agreement with a statement about staying active. And when we ask them if they've been exposed to the campaign messaging, have you heard the advertisements? And they say yes. Then 80% of those people agree that they should stay active. So we do know that public beliefs can be changed. In our evaluation, though, this has not correlated with a behavioral change. We haven't seen the same kind of impact the Australians did, where we're seeing more people staying at work and less people going to the doctor looking for an MRI. But we changed their beliefs, and that was quite amazing, right? A huge impact when you think about this as a whole population. In Alberta, we have 3 million people, and not the size of Switzerland, but we were happy with that kind of an impact. So that's one potential strategy. Go out and change people's minds. We're able to talk them into the medical model and make them all afraid, so let's maybe talk them out of it. Secondly, promising interventions related to social and work systems. We know that work loss and work disability because of low back pain and many other health conditions are multi-system problems. It has to do with the types of benefits that people are eligible for. Are they eligible for benefits in the first place? How much income replacement benefits do they receive? These are the types of system issues that I'm talking about here. We know that there are substantial differences in claims for disability benefits in different countries. The United States has a 60 times higher benefit rate than Japan. 60 times more workers file claims and go off work when they have back pain than the Japanese. We know that claims in Brazil are 5 to 6 times higher in some states versus others within the country itself. So interventions targeting these work systems try to optimize our compensation systems. These are hard to do, and they're really hard to evaluate. But I think that it's an area that has tremendous potential. Examples are switching from fault-based insurance-type programs to no-fault insurance-type programs. There was one in Saskatchewan, Canada, study led by David Cassidy, natural experiment, very kind of well-known one, more from whiplash. But they found the same observation in back pain. It was published a little bit later. But when there was a switch to a no-fault insurance plan, they had a very dramatic reduction in disability from back pain. And that's been found in a couple other areas as well. So the switch, I think, that has to go is from a passive benefit system where you're paying people to be off work to employment promoting systems. And there have been some good examples in Europe here. There's been one in a project in the Netherlands as well that was quite successful. Hananama published a paper looking at, well, it was a 6-country study looking at how different policies, compensation system policies, lead to different recovery patterns. And he found quite dramatic differences between different systems. Different systems led to widely different outcomes. And what they found was that best outcomes were within the Netherlands after they had implemented more of an employment-based disability support system. This was published in 2009. But again, these types of studies are hard to do, and they're fairly hard to interpret. We could easily make the case that there's many, many differences between these countries rather than their compensation system. So it's hard to do a good randomized controlled trial at this level. There have been some very good randomized controlled trials done of integrated healthcare and workplace type interventions. These are based mainly around the Sherbrooke model, Patrick Loisel, published back in the late 1990s. This was a study done in the Netherlands, randomized controlled trial of integrated care to reduce disability from chronic low back pain in private and working life. Basically, when I say integrated care, it was having the doctors, therapists, chiropractors work with the workplaces, provide recommendations for suitable activity, using participatory ergonomics with the workers to find out what they're capable of doing, what they need to avoid at this point until they're a little bit further recovered. And the result from this trial was that the integrated care substantially reduced disability. More people were going back to work quicker and more sustainably. They were staying back at work. Interestingly, though, they didn't find any impact on pain. So people were returning to work with pain. They didn't reduce or cure the pain. They're just more active. Cost effectiveness study that went along with this RCT showed that for every $1 invested in integrated care, it returned an estimated $40. So very high return on investment. Definitely very promising integrating healthcare and workplace solutions. How about healthcare solutions? What can we do different in our clinics, in our hospitals? 3 areas of reform. Number 1 is focused implementation of best practice. So we have these guidelines, we know the evidence, we've known this for years and years. In many cases, we've known this for decades, and yet it hasn't necessarily translated into our practices or our healthcare systems. In Alberta, one of the things that we've done was for every doctor and physical therapist ordering an MRI for a patient with back pain, they had to fill out a checklist, and they had to meet these criteria. And if the patient didn't meet these evidence-based criteria for needing an MRI, they didn't get an MRI. That had a very dramatic reduction in the number of MRIs that were done. That's what I mean by focused implementation of specific best practice recommendations. Number 2 is reforming the education and training of healthcare professionals. We kind of train and teach within silos. I think that we need to do a lot better at providing multidisciplinary and interdisciplinary training programs. Lastly, changing healthcare systems or pathways. So this is basically about getting the right treatment at the right time. So clinical pathways are integrated multidisciplinary strategies to organize the timing, sequencing, and coordination of care to get better outcomes. Traditional pathway is someone has pain, they show up, they go to their doctor. That medical doctor is the frontline professional, and the doctor makes the decision to refer to a chiropractor, physical therapist, or a surgeon, whatever it may be. We think that we need to get away from that and reform these pathways so that healthcare professionals with the best training, the most related training, and who practice most consistent with evidence-based guidelines are the first line solution. There was one systematic review looking at care pathways. They found 4 examples in the literature, but there was no data. So we don't know at this point if it was successful. In Alberta, we have something called Spine Access, which has physical therapists and chiropractors as the first line of care. Again, getting away from the medical doctor. And we don't have any data from Alberta either. What we do have is some experience with our workers' compensation system of doing this. Back in the mid-1990s, we implemented a continuum of care. We evaluated that over a 10-year period. We did find that getting the right care at the right time leads to better outcomes, timely assessment and reassurance, acute stage pain coping strategies, Goldilocks, multidisciplinary functional restoration, not too early, not too late is what I mean by Goldilocks, as well as integrated workplace interventions. Psych-informed care, I'm going to skip over these because I got one more paper to go to. Lastly, this was the 3rd paper in the Lancet series, Call for Action. With this paper, the idea was to really try to get the message out that things need to change. We need to avoid overuse of low-value care and underuse of high-value care. So in this paper, we summarized 3 key messages. Number 1 is to use positive health. This is the ability to adapt, to be resilient, and to self-manage in the face of social, physical, and emotional challenges. Number 2, the recommendation in the paper is to address these widespread misconceptions, both among the population and healthcare providers about what causes back pain, what it's going to lead to, as well as effectiveness of different treatments. A real call in this paper to avoid harmful and useless treatments. And lastly, only include treatments in public reimbursement if evidence shows that they are safe, effective, and cost-effective. So as part of this call for action, we actually hired a marketing team in Switzerland here, and they led a global blitz to get this information out. You may have seen some of the articles in the newspaper. It was covered by BBC, The Guardian, NBC in America, really around the world. There was information covering the back pain crisis, highlighting back pain. I wouldn't say that I necessarily love all of the key messages there about all healthcare being a waste, but it was the reporter's attempt to summarize and raise awareness of the problem. So I think overall the goal was reached, but we have much more to do. So that is the summary of those 3 papers and some of the work that we've done in Alberta. I wanted to acknowledge some of the slides came from colleagues on the Lancet series. And I wanted to leave with this, end with this quote from the Lancet Global Burden of Disease study. Even if cures for back pain are not yet available, the clinical goal of preventing disability is attainable. There's much that can be done, and evidence does support many things that we can do as healthcare providers to reduce disability. And with that, I think that we're going to open it up for a few questions or discussion. Yes, go ahead. Well, I think we have a microphone.
Yeah, so
It's just for the people online.
Yeah, we're ready for questions, and I think we wait for the microphone. All right.
Okay, thank you for the very interesting presentation. I'm curious to know from a public health perspective what you would think about sitting is the new smoking.
Yeah, you do hear that a lot. That's really controversial, and I don't necessarily agree with it. I don't think the evidence is necessarily there to support that message. I don't think that it's as bad as smoking. Certainly it's one of these catchy slogans that sinks into people's minds, but I think it has the potential to lead to a lot of fear as well. So I don't necessarily love that one.
Yeah, I guess I'm speaking a little bit from personal experience with back pain. When I'm at work and you're sitting a lot for 8 hours, or also with a table that goes up and down, you can feel the effects of this versus when you're at home and moving around and being active. Mm-hmm. So just, yeah.
So I think that the messaging that needs to go out is movement. Sure, you can't sit still for 8 hours a day. I don't necessarily think that it's as bad as smoking, but the messaging has to be, get up, change your position, go for a walk every 10 minutes, stretch every 15, whatever it may be. Keep moving. And again, that kind of speaks to the design of our workplaces. That's not necessarily a compensation system, but I think there's a lot that our workplaces can do to make our jobs more accommodating and make it so that we can move more.
Any other questions? There's a couple of questions here.
Yes, thank you for this interesting presentation. You mentioned the spine axis, where chiropractors and physiotherapists work together and were the first-line treatment or first-line healthcare providers. What was the experience with that model? Can you elaborate on that?
Yeah, so the model, it wasn't a randomized controlled trial. We developed a model and we implemented it in 3 different clinics. I was on the team. I had a very minor role in that one. But when it was rolled out, one of the clinics was in Fort McMurray 2 years ago, where that large fire took place. It was the town in Alberta that burned down, and that clinic actually was involved in that fire. And so the study didn't go as well as planned. But I can say that the other 2 locations are continuing, and they've anecdotally had good success, enough to convince the healthcare system managers and the higher-ups to expand more broadly across the province. So I think that the message has been good. In Alberta, we have had direct access to physical therapy and chiropractic for many years, and so if someone does have pain, they can go directly to the PT or to the chiropractor. Direct access as well to acupuncturist. Yeah. And that experience as well has been quite good.
Thanks again for your nice talk. Can you say more about what types of exercises are maybe the best? Is it strength, is it mobilization, or is it just simple movement in whatever type of types of movement?
Mm-hmm. So the evidence. So the answer to this is going to come from the latest systematic review looking at exercise. Basically, when one specific form of exercise is compared to another specific form of exercise, whether it be motor control to Mackenzie extension or whatever it may be, they always get the same outcome. So the recommendation is typically recommend something that your patient likes doing. Mm-hmm. Engage in a conversation with your patient. Find out what they have had success with in the past. What do they like to do? What are they most likely to continue doing when you're done with the treatment program? For me, it's I like to play basketball, but it's not the best. I got this knee problem. But I typically recommend, as much as possible, a balance of aerobic activity, some strengthening, some flexibility, and then something for fun, something that they like to do. For me, it's basketball.
There is another question.
Thank you very much for your speech. One question, so about changing beliefs. What population would be best? Shall we start with our kids, or is it at what age? So is it best to intervene with changing beliefs?
That's an excellent question, and I think that's probably the million-dollar question. We don't know that at this point. It kind of makes sense that you would start with children, and I know that there are some programs providing education in the classrooms of very young children, elementary age children. The studies are not there to support that fully. They just have not been done yet. We in Alberta have been trying to find out where we've had the most success so that we can target our messaging a little bit more effectively. And there's certainly some measures related to socioeconomic status, lower income, lower education. We have a little bit more success changing their beliefs, and we think that some of the messaging should be targeted there. But otherwise, we don't really know at this point.
Thank you. Here's another question here. And meanwhile, I'll ask the question, in terms of changing behavior of the healthcare provider, this is one of the 3 actions on the action plan. Do you have any experiences from, I mean, you worked in the Millard Rehabilitation Center, and maybe you can, you have any experiences with changing behavior of the healthcare providers in terms of training, or how effective are intervention with healthcare providers in changing outcomes of patients?
So I'll go back to this slide. I don't think it's up here yet. I talked about this very briefly, but this was the implementation of a continuum of care model, trying to get the right care at the right time to the right patient. Before this, it was more like the Wild West. Patients would get a wide variety of treatments. For physical therapy and chiropractic, the workers' compensation system would pay for up to 2 years. And so when I first started practicing, I was in a chronic pain clinic, and I was seeing people who had been in physical therapy for like 150 sessions, sometimes 200 sessions of hot pack and ultrasounds. It hadn't had any kind of impact on their pain. And we couldn't change that behavior until we changed the way that the care was funded. So one of the biggest things that this continuum of care did was get away from that 2-year anything goes period to a very focused 6 weeks acute, then you do an assessment, and then you move into a subacute where you consider multidisciplinary care. Changing the way that the providers were changed had a huge impact on the way that they practiced. And every provider that treated injured workers in Alberta went into a contract type negotiation, and they had to agree to provide evidence-based care. So that was one way that we had a bit of success, was in changing the way that healthcare providers were reimbursed. We did another study related to motivational interviewing. We thought that the providers were giving too much kind of like mechanical therapy. We wanted to try more of a psychologically informed approach to care, try to change the way that the providers talked and listened and interacted with the patients. And this trial was also very successful. So I do think that some training related to psychologically informed care can change the way that we practice as well. I think that the impact here was in teaching the providers how to listen and find out what exactly was the barrier to the specific patient and the specific worker, and then work with them to come up with a solution. So we had a sizable benefit from a motivational interviewing type intervention.
Thank you. There's another question here.
Yeah, thank you very much for your interesting talk. I see a huge conflict here in Switzerland, and as I think that your healthcare system in Canada can be compared with ours, high quality and also very expensive, costly insurance system, I would like to know about your experiences. But let me first share the conflict that I see. In Switzerland, we do have evidence about all the facts that you told us. The recommendations like a bulged disc does not necessarily explain the symptoms, or that the findings in imaging is not necessarily the pathway of treatment. We do have that evidence, but this evidence and the consequences in treatment options are not according to these recommendations, because the conflict with economy. And for example, in Switzerland, we do have the highest density of MRI imaging devices, and we do have the highest density of computer tomography devices. And so from an economic perspective, we are very much interested in using those devices. And so I see the huge conflict in our healthcare system that evidence can't be integrated into the policy, into the policy making strategies and into the healthcare system. And I would like to know, I guess that you have kind of same problems in Canada, and I would like to know how you deal with them.
We definitely have the same problems, and it's not just Canada and Switzerland. I would say that this is the problem worldwide. Every healthcare system is struggling with this kind of problem. I don't think that I necessarily have solutions. I will say that one of the things that we did with this Lancet Low Back series is create a policy brief. So the steering committee worked with the Swiss marketing group, and we summarized the messages in a very focused way, in a way that insurers and healthcare funders would kind of pay attention to, and we're thinking that that would make an impact, and we tried to target the policymakers, giving this information to them. I know that this kind of work takes a long time. It's probably going to take decades, and when there's financial incentives, profit incentives, it's probably unlikely to be successful, but something really needs to change. Yeah, and I wouldn't say that I've really got a solution about that.
All right, I think we are at the end of the talk. I would like to thank you again. We have, of course, chocolate
yes.
for our guest from Canada, a little gift from Lederach.
Yes,
You've been there already. Before your last visit, I would like to thank the audience, everybody out there who was following our guest lecture, and I'm looking forward to our next guest lecture in January. Thank you again, Doc, for coming and for your excellent talk. Thank you.
Thank you.